Hello everyone, welcome back to the channel. When treating anaerobic infections, one of the most common questions clinicians ask is, do I need to add metronidazole? For many newer antibiotics, the answer is yes, because they lack reliable anaerobic activity. However, a few newer agents have excellent intrinsic anaerobic coverage, allowing them to be used without adding metronidazole in appropriate clinical situations. In today's video, we'll discuss only those newer antibiotics that have clinically meaningful anaerobic activity and generally do not require additional metronidazole. Let's get started. For an antibiotic to be used alone against anaerobic infections, it should have reliable activity against Bacteroides fragilis group, activity against other clinically important anaerobes such as Prevotella, Porphyromonas, Fusobacterium, and Clostridium, good tissue penetration, and clinical evidence supporting treatment of polymicrobial infections. Let's review these agents one by one. Number 1. Eravacycline. The best new anaerobic antibiotic. Eravacycline is a fully synthetic fluorocycline, approved for complicated intra-abdominal infections. Spectrum. It has excellent activity against Bacteroides fragilis, Prevotella, Fusobacterium, Porphyromonas, Clostridium species, and Peptostreptococcus. In addition, it covers ESBL-producing enterobacterals, many carbapenem-resistant enterobacterals, MRSA, and VRE. Advantages: outstanding anaerobic activity, excellent tissue penetration, low resistance rates, and active against many multidrug-resistant pathogens. Limitations: it does not cover Pseudomonas aeruginosa, so it should not be chosen when antipseudomonal therapy is required. For complicated intra-abdominal infections without concern for Pseudomonas, eravacycline can be used as monotherapy, and metronidazole is not required. Omadacycline belongs to the aminomethylcycline class. Although approved for community-acquired bacterial pneumonia and acute bacterial skin and skin structure infections, it also has reliable in vitro activity against many anaerobic bacteria. Active against Bacteroides species, Clostridium species, Peptostreptococcus, and Prevotella. Advantages: available in both intravenous and oral formulations. Excellent tissue penetration, useful when MRSA and anaerobic coverage are both desired. Clinical use: while not specifically approved for intra-abdominal anaerobic infections, metronidazole is generally unnecessary when omadacycline is selected for infections caused by susceptible anaerobic organisms. Clinical experience for deep anaerobic infections is, however, more limited than with eravacycline. Tebipenem is the first orally available carbapenem developed for systemic use. Like other carbapenems, it has intrinsic activity against Bacteroides, Prevotella, Clostridium, and Fusobacterium. Therefore, additional metronidazole is generally unnecessary. However, its current approved indications are limited, and more clinical data are needed before it becomes widely used for anaerobic infections. An approved first-in-class oral carbapenem antibiotic to treat complicated urinary tract infections, including pyelonephritis. It offers an effective outpatient alternative to intravenous therapies for adults with limited treatment options. Many clinicians assume that every new broad-spectrum antibiotic covers anaerobes. Unfortunately, that is incorrect. The following agents should not be relied upon alone for anaerobic infections: ceftazidime-avibactam, ceftolozane-tazobactam, cefiderocol, cefepime-metazobactam, sulbactam-durlobactam, aztreonam-avibactam. These antibiotics generally require additional anaerobic coverage when anaerobes are suspected. Before we conclude, remember these important points. Eravacycline is currently the most important newer antibiotic with excellent intrinsic anaerobic coverage and can be used without metronidazole for approved indications. Omadacycline has reliable in vitro anaerobic activity and may be used without metronidazole in selected susceptible infections, although clinical experience is less extensive. Tebipenem, an oral carbapenem, also has intrinsic anaerobic activity, but its role in anaerobic infections is still evolving. Always ensure adequate source control, because no antibiotic can compensate for an undrained abscess or uncontrolled focus of infection. Finally, choose therapy based on the site of infection, local susceptibility patterns, severity of illness, and antimicrobial stewardship principles. Thank you for watching. If you found this update useful, please like, share, and subscribe for more evidence-based critical care content. See you in the next video.